Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient comes to clinic after a swimming holiday with severe ear pain, a blocked ear, and discharge. They tell you the pain is much worse when they touch the ear or try to insert an earbud. That simple detail already points you towards otitis externa rather than middle ear disease. Otitis externa means inflammation, usually infection, of the external auditory canal. The key anatomical point is that the disease is outside the tympanic membrane, in the skin-lined canal between the outer ear and the eardrum. Acute otitis externa lasts up to 3 weeks. Chronic otitis externa persists for more than 3 months. To really master this topic, think of otitis externa in 4 steps: barrier failure, bacterial overgrowth, canal swelling, and pain with conductive hearing loss. The normal ear canal is not just an empty tube. It has cerumen, or earwax, which creates an acidic, protective, water-repelling barrier. This barrier discourages bacterial growth and protects the delicate canal skin. When that barrier is disrupted, the whole problem begins. Water exposure causes maceration of the canal skin. Cotton buds and other foreign bodies cause microtrauma. Eczema and psoriasis damage the epithelial surface. Hearing aids and narrow canals trap moisture and debris. Warm, humid conditions make all of this worse. So the aeroflow is: moisture or trauma leads to loss of the acidic cerumen barrier, then epithelial injury, then edema, then bacterial proliferation. The classical bacteria are Pseudomonas aeruginosa and Staphylococcus aureus. Pseudomonas is especially associated with moist environments, which is why this is sometimes called swimmer's ear. Now connect the anatomy to the symptoms. Pain in otitis externa can be surprisingly severe because the skin of the external auditory canal is tightly adherent to cartilage and periosteum. When this skin becomes odematous, it has very little space to expand. The swelling stretches richly innervated tissue, so the pain feels disproportionate. The key clinical clue is tragal or pinna tenderness. When you press the tragus or pull the pinna, you mechanically move the inflamed canal skin. That is why the patient winces. This is a very useful bedside discriminator. In otitis media, the problem is deeper, behind the tympanic membrane, so moving the external ear is usually not the main pain trigger. On otoscopy, you may see erythema, canal edema, debris, otorrhea, and sometimes such marked swelling that the canal is almost closed. The patient may describe deafness, but this is usually conductive and temporary. It happens because swelling and debris physically block sound transmission through the canal. Diagnosis is mainly clinical. You do not need to swab every patient. Swabs are useful when the disease is recurrent, chronic, severe, not responding to standard treatment, or when the patient is immunocompromised. MRCP trap. Routine swabbing in uncomplicated acute otitis externa is usually unnecessary. Always try to assess the tympanic membrane if it is visible. This matters because a perforation, grommet, or uncertain tympanic membrane status changes the choice of eardrops. Some drops are potentially ototoxic if they pass into the middle ear. Management starts with simple but important measures. Keep the ear dry, avoid cotton buds and instrumentation, and give proper analgesia. Do not underestimate the pain. These patients may need regular paracetamol, non-steroidal anti-inflammatory drugs if appropriate, and occasionally stronger analgesia. For typical acute bacterial otitis externa, treatment is topical antibiotic drops, often combined with a corticosteroid, usually for about 7 to 14 days. The steroid is not just cosmetic. It reduces edema, which reduces pain and helps drops penetrate deeper into the canal. Less swelling means better delivery of the antibiotic to the infected epithelium. If the canal is very swollen or occluded, drops may simply sit at the entrance and never reach the target tissue. This is where good ENT thinking matters. The patient may need oral toilet, microsuction, or an earwick. An earwick is a slender absorbent sponge or cotton device placed into the swollen canal. When soaked with antibiotic drops, it expands and keeps the medication in direct contact with the inflamed canal skin. In other words, it solves the drug delivery problem. Do not confuse topical treatment with oral treatment. Oral antibiotics are usually not needed for uncomplicated otitis externa because the infection is on the surface of the canal skin, and topical therapy delivers high local concentration directly to the site of infection. Oral antibiotics become relevant if there is spreading cellulitis, systemic illness, diabetes, immunosuppression, or concern for malignant otitis externa. Another MRCP trap: avoid aminoglycoside ear drops if tympanic membrane perforation or a grommet is suspected, unless this is specialist directed. The safer principle is to use a non-ototoxic option when the middle ear may be exposed. Now let us focus on the dangerous complication. Malignant otitis externa is not simply a painful ear infection. It is invasive infection spreading from the external auditory canal to the skull base, causing skull base osteomyelitis. The classic risk groups are patients with diabetes and immunosuppressed patients. The red flags are severe nocturnal otalgia, granulation tissue in the canal, cranial nerve palsies, diabetes, and immunosuppression. Nocturnal pain is important because deep invasive infection often causes relentless pain that is worse at night. Granulation tissue, especially near the bony cartilaginous junction of the canal, should make you pause. Cranial neuropathies are a late and serious sign because the infection may be involving the skull base and nearby foramina. If you remember one thing, remember this: uncomplicated otitis externa is painful but local and is usually treated with topical therapy. Malignant otitis externa is invasive, dangerous, and needs urgent ENT assessment, admission, imaging, and systemic anti-pseudomonal treatment. Do not confuse otitis externa with otitis media. Otitis externa gives tragal and pinna tenderness, canal oedema, debris, and pain on moving the external ear. Otitis media gives middle ear inflammation behind the tympanic membrane, often with a bulging red drum, reduced mobility, and less dramatic pain when the pinna is moved. So the practical ENT approach is: look at the canal, look for tragal tenderness, assess the tympanic membrane if possible, decide whether topical drops can actually reach the canal skin, avoid ototoxic drops if the drum is not intact, and always screen for malignant otitis externa in diabetic or immunocompromised patients with severe pain. Quick recall: a swimmer develops severe ear pain, discharge, temporary conductive hearing loss, and marked pain when the tragus is pressed. What is the anatomical reason for the disproportionate pain? The answer is that the inflamed external canal skin is tightly adherent to cartilage and periosteum, so oedema stretches richly innervated tissue and causes severe pain. A diabetic patient has severe nocturnal otalgia, granulation tissue in the ear canal, and a new facial nerve palsy. What diagnosis must you suspect, and what is the immediate action? The answer is malignant otitis externa with possible skull base osteomyelitis, requiring urgent ENT assessment, admission, imaging, and systemic anti-pseudomonal treatment. Do subscribe to the channel for further videos.